Two appointments? One. That's good. That means seen enough thyroids, right? Huh? Yes? Right. Okay, you have seen enough thyroids, but have you calculated enough thyroids? I'm coming from the straight from the seniors, not seniors. Yeah, seniors, number seniors. They are final exam. For today's exam also there were 3 thyroids. 2 thyroids are short cases, 1 thyroid has a long case. Short cases, thyroids. I mean, some of the people. Not very good. You see, when you mess up the thyroid, right? When you mess up the thyroid in an exam, right? Basically, that's that. Thyroid is a long short. You will learn about it. And there are short cases, there are spots, there are long short cases. Short cases, there are various types. Thyroid is a typical long short case where you take some time. Exam short cases are divided. You know that you have taken exam. You know, because by 4th year you should know these things. I mean, you know that babies anymore to kind of support. You have gone beyond the infant stages now. But you have to mature fast, because some of the people who have come to the exam today will become very mature, and the maturity will be shown in the marks they get. It is not a joke, right? So, because the whole problem is the thyroid. As far as we are concerned, medical thyroid is different, surgical thyroid is for general surgery. Your exam is a general surgical exam, correct? It's about one of our bread and butter things, right? So, please, and it's one thing that examiners, I mean my co-examiner was an MSc examiner, and all the time he was starting the thyroid, they are even thyroids, because thyroid is a very good case to see a lot of things. There is a coaching patient, decision of clinical science, and it's one thing that any student cannot say in this country. Abroad, certain countries, yes. In this country, you cannot say that you haven't seen examine the thyroid and come to the final year. So, you understand what I'm trying to say? I mean, it can't. That means that person hasn't come to any clinical. Right? Okay? But it's not something like a, as you see as a parotid cancer or something. Right? It's not. You can go to the exam without seeing that. You should, ideally, but without seeing that parotid lesion. You can take the place. You can say, I haven't seen something like that. But can you say that you haven't seen a thyroid? Yes, absolutely. Right? Okay? So, thyroids, hernias, right? We made repeated mistakes in examination technique and so on and so forth. You are going to get realized. Right? It's not like something like that. So, just is careful. These countries, that countries, right? As we don't have it for the procedures. So, what if? Right? And what I'm trying to say is a few things about how the other second things. Please don't try to bypass examination. You can't do that, right? And there is nothing called the correct technique or the wrong technique, like all the best technique. There's nothing like that. We will just give you some guidelines. But that doesn't mean that you have to do it only in that. As you go past your clinical tutors or teachers, you will see various techniques, like variations of it. So that's all right. As long as you do something sensitive, right? Okay? Right? Have an order, a method. Don't miss without missing the major things. And have a general common sense about answering a direct question, right? In a short piece, right? Okay? So, therefore, please pay attention. Please ask questions. Please clarify and do a lot of practice on your patients. You have enough thyroid patients in research equipment, right? Okay? Every time you see a patient, thyroid, hernia, whatever, doesn't matter. Don't just run to look on a nice thyroid nodule. No. Do a proper examination, general examination, and come to the lung. There is a specific way of examining the neck. Right? And because we expect you to do those things at the Alright. So basically a non-number to do pathophysiology and pathogenesis of thyroid that is, can be done of people. Right? So correlating pathogenesis of thyroid in a very detailed presentation, that is important because today we have that also thyroid is important. Right? To learn when to substitute medications in a laboratory, we ask this question. Yeah? To learn some schedule, to learn how to work out clinical diagnosis. Very important, right? So basically, right, there's no point in writing. This is not a theory. I'm just trying to tell you, right? So basically, morbid enlargement of the thyroid is, right? So and you have a lot of causes of thyroid benign and I don't want to go into details, right? Okay, right? So so basically various age groups have different etiologies, different common etiologies of thyroid, right? Okay, just keep a little about that. A child of very puberty age, for example, right? Okay, smooth uniform enlargement of thyroid, and this is physiological, right? Okay. It's a demand versus supply situation, right? And usually you don't need treatment for that patient. Right? Okay. Right? Okay. So now, unless so in a child like that, usually what you do is you see the thyroid enzyme levels, TSH. If the TSH is high, that means there is a demand versus supply problem, right? And if the thyroid hormones, T3, T4 levels are low, you have to supplement, right? So if you don't do that, what happens is this second scenario, right? Certain parts of the gland are necrotic, and then you develop certain irreversible changes in thyroid, which is called colloidal, which is the commonest thing, right? Okay, commonest thing, right? Okay, so. And if this problem continues, you have hyperplasia, degeneration, cyst formation, there is multiple nodules and fibrotic changes. Fibrotic changes are associated with thyroiditis as well. Right? Okay? So that is the usual etiology of multinodular thyroid. And most thyroids that you will see in the cases are multinodular thyroids. Right? Okay? And then that is the thyroid taken as a gland, right? Of course, thyroid is a functional gland. You must remember that it produces the important hormone, thyroid, right? Okay. So you have, for example, you have middle age people who have multinodular for a long time, and perception weight loss in fact of increased appetite, deep intolerance, palpitation, one of the long cases today, right? 10-year-old boy, right, in a 40-year-old patient. The patient is there in the body, right? No, you are not there. Okay, tremors, all these things, and multinodular. You see, usual scenario is one of the nodules have become autonomous, right? Okay, and produces pyroxidinases, right? Okay, right? As opposed to same patient from the short cases, right? The younger, right? At this, right? Okay. Like diffuse thyroid. Diffuse, now, that's not things that people are making mistakes today again and again, When you say diffuse enlargement, that means the left lobe, right lobe, and the isthmus are uniformly enlarged, right? With no difference of size, of that size to this, right? Or what? You do not feel anything different, uniformly enlarged. That means diffuse. Anything else, like variation in size, could be not, right? that you can't feel. Very, very, as a patient with the right side nodule and it continues with the nodule in this one, left side nothing much to feel. I mean, while the candidate is going on saying this is a diffuse going, it can't be diffuse going. If you can't feel the left side, how can it be diffuse going? Right? Be very careful in this terminology. Right? Okay? The senders get offended when you repeatedly use it. Right? Be careful. Right? So they are usually, that means that's a nodular going. Right? So Graves' disease, as you know, right? Or autoimmune thyroiditis, but not primary thyroiditis. That is usually right in young females. With what is the thing about Graves' disease? You know this. What is the common thing about Graves' disease? How do you recognize? What? They are very prominent eyesight. They are very prominent eyesight. They have a lot of prominent eyesight. Still patients with prominent eyesight. Right? Okay. Right? Okay. So, yeah. So basically, right, one of the things that you can have a clinical problem is that you are given to examine a thyroid. We do that. Right? Right? You feel only one nodule on one area of the thyroid. Rest of the thyroid is not there. Right? Okay. So remember, it could be many things. Right? It's most of the time it is single nodule or multinodular going. Right? This differential diagnosis has to come because the problem is the rest of the nodules are small and the thyroid is small and you can't feel. Right? Okay. But a nodule felt, right? Statistically, a single nodule felt on palpation on the left side or the center of the thyroid is most of the time a single nodule or multinodular. Right? We can know that by doing analysis. Okay? It could be thyroid element. That is a true single nodule. Right? Thyroid cyst. Right? Okay? And the chances of that becoming a thyroid single nodule when thyroid carcinoma is nothing but 10%. Right? What happens is when we have there's a nodule, but it's most likely the first thing comes is thyroid carcinoma. No. Right? Thyroid is one top. Alright? Right? Okay? So right? So then of course that is a nodule. Then you have the smooth uniform enlargement, that is smooth enlargement, physiological hyperplasia is generally that, right? In initial parts of the colloid girdle, but later on the colloid girdle become colloid nodular, right? I told you how, right? Right? They can be, but initial colloid girdles can be thyrotoxicosis in Graves' disease. That's usually that is because the entire gland becomes hypoplastic, right? Due to problem in the hormones. So those patients also it's smooth. Right? Graves' disease specifically you get a smooth firm gland. Right? Alright. So when it's a nodular enlargement, I told you whether it's a single nodule or a multinodular goiter or is it a single nodule. Right? Right? So this varying diagnosis, right, you can make on a thyroid, a single nodule of thyroid. Right? Thyroid thyroid carcinoma, they can be multiple nodules, they can be two thyroid multinodular goiter, toxic nodular goiter, carcinoma, of course, that it can be even hypothyroid multinodular goiter as well. Right? Because if your goiter is so disease, right, thyroid status can be hypothyroid as well. Right? Even that is seen. Right? So the nodular status or the physical status of the goiter and the thyroid status of the patient. Right? Both have to be mentioned when you talk about thyroid. Right? So the clinical approach therefore, right, always has to correlate with the pathology physiology and pathogenesis of thyroid gland. Now this is the important thing that we are trying to tell you, right? I mean, that's why you cannot buy now. Right? You know, when you examine the thyroid, you have to think, right? Okay, what particular pathological process might this patient be going through, right? Okay, the patient is obviously toxic, right? Right? Then, you know, it can be only one of few things. It can be an absolute smooth enlargement, that is great disease in a young patient. Otherwise, it's a toxic multinodular, that is or a single nodule, whatever, within the nodule or comprehensive. You understand? Right? Okay. So, likewise, you have to, you know, kind of, depending on the patient and the findings, you have to take the whole thing as a patient as a whole, right? And connect the physical examination finding and the thyroid status and make a reasonable diagnosis, right? So that's why you cannot try just a blanket policy for thyroid, right? Okay. Right? So now in that whole scenario, suspecting malignancy is important, right? Either in a single nodule or in multinodule or in a different type of dominant or prominent nodule in a multinodular goiter, right? Right? The clinical features to suspect malignancy is important, right? Okay. And yeah, so that's what we would do, right? When do you suspect malignancy? Having said, right? Usually all these thyroid problems are long-standing problems, right? But short history. Patient noticing the lung very recently and lung becoming problem. That is rapid enlargement, right? Change of voice, very, very important sign. Okay, don't ever miss this in X-ray. Right? If the patient says, or patient might not even say it, but when the patient talks, you notice that there's subtle change of voice or hoarseness, right? Right? Hoarseness is the fine nature of the voice is gone, right? That is a very important sign, right? Okay. Then fatigue, you know, not feeling all right, firm, fixed, gastric and firmness. Even in a multinodular goiter, when one nodule is firm and it's not mobile, that will be very suspicious, right? And if there are cervical nodes, really clear. All these things should tell you, right, whether the goiter has become malignant. But on the other hand, right, you must also remember that a firm tender gland you can get in thyrotoxicosis, other patients can. There are like that, you know, a tender and firm gland in thyroiditis. Right? Okay, you can have a nodule, it is firm and tender. And that doesn't mean that the patient is having once again malignancy. Right? Okay? Things can overlap, but these things are important features. Right? Yes. You will see better patients, right? Anyway, right? Eye signs, then the thyroid status, right? Okay. You know these things, isn't it? Very boring to tell. What is this sign? Huh? Exophthalmos. Right? Why do you say it's exophthalmos? Huh? Yeah, staring look can be there, but you know, it's really important, right? Okay? The portion of the sclera is seen, right? Between the upper lid marginal, the cornea and the upper lid, right? Okay? Your clinical sign books have this, right? Okay? Right? Because we ask, right? Right? The normal patient, usually the upper one that is covered by the upper lid, right? So that is exophthalmos, right? Right? Okay? Then what is proptosis? How do you look at proptosis? Okay, when you take some thyroid, you must always look at proptosis. How do you do that? Huh? What? Itu kalau dilakukan doa, right? You need to read your physical examination book and practice on patients. Proptosis in general seen from behind the patient, right? Okay, and you align the patient's forehead, right, in the line of vision, and just watch, right, at the upper his eyebrow, and if the eye is seen, right, jutting out, then that means the patient has proptosis, right? Okay. Did you understand? Oh. Right. Come here. Move, right? Right, okay, what you do is, right, like that, right, you keep the patient steady and ask the patient to open the eyes and look front, right, and look like that, okay, right, in the line of at the eyebrows. Usually, you will see the upper eyebrows, right, okay, but if you see a part of the eye, then that means generally the patient has proptosis, okay. Right? So patients with exophthalmos, gross exophthalmos usually have proptosis. Right? Right? Lid light? No? Lid reflection? Right? Okay. Right? Ophthalmoplegia? Right, lid serous. Right? Okay. Right? So, yeah, so those are the things, right? The thyroid eye signs, right, are very important, right, in a patient with toxicosis, right? Then of course comes the peripheral signs, right? I will not go into the clinical features. I mean, they are very straightforward, right? A toxic patient and a hypothyroid patient. But remember, sometimes certain patients have mixed pictures, right? Some of you have seen a practice that are very nice in the patient, right? You know, sometimes you have, menorrhagia and constipation. You know, doesn't work, right? Okay. Like that. But it doesn't matter. You just see what type of features does the patient have most, right? And generally go in that line, okay? Right? But those are very basic stuff. You know those, isn't it? Patient features with hyperthyroidism, hypothyroidism. I don't want to have to list out those things, right? But those are the things that we must ask for the patient pick. Right? And then the eye signs and hand signs are very important. Right? Okay? In doing the thyroid status. The pulse, the nature of the pulse, right? Okay, the tremors, the sweating of the palms, right? And those things at least, right? We expect you to check. Alright. Alright. But I can go on lecturing for hours and hours, but it's absolutely no point. We don't even believe in this lecture because absolutely no point unless you get down and do it. You understand? So please make a resolution, and maybe a resolution that you will examine, you see, at least 50 goiters, 50 different. It's very easy to do, right? Okay. That's really how many goiters you do, right? 50 different goiters before your exam, right? Please do that, right? Okay. And because person to person it changes, pathology to pathology it changes, and definitely 100%, more than 50% of you will get a goiter in the exam, right? And if you mess up the goiter, once again I will guarantee this glass of water is another important thing, right? Because you are generally given the patient and you are being asked, examine this patient and examine this patient's neck. Or this patient has come with a neck lump, right? Examine and tell us what you think, right? Right? One of the key things to establish is that this lump is a thyroid. One of the ways of doing that, or is attached to the pathway of the development of the thyroid, which usually things like thyroidosis, or something is attached to the deep cervical fascia, right? Okay. How you demonstrate that is you getting the patient to swallow, right? Okay. So usually in the exam setting, you have this glass of water, right? Now you must practice this. When you have to see patients, always give them some, because that also needs a bit of practice. Because if you just get the glass of water, the patient just drinks it, that's it. And when you generally drink, you tend to bend the neck, right? You won't see anything, right? And that's what happens. So in the exam, when you give the glass of water itself, we know the students who have examined thyroids and who haven't not examined the thyroid. Because the correct way of doing it is, you are to tell the patient very clear, I'm giving you a glass of water, you take a sip of water into the mouth and don't swallow until I say it, right? And take the glass back, keep it on the side, extend the neck, right? Okay, and get the patient to swallow. So that you and the examiners both see that the lump is nicely moving upwards and comes back to the original position. Ever thought of it? That way? No. That's the thing, right? That's why we give in a lecture thing, that's why we are doing a critical examination. No. You understand? You think we are crazy, but we have to do this because of these mistakes. Understand? Right? Okay? Okay. Yeah. Now, that is the way to do it. So, what the examiner is, right? Okay? It is actually one procedure. I think. When patient follows like that, that's a very good time to look and see most of the things, right? In a multinodular body, most of the nodules become apparent or seen when the patient does that. Did you notice that in this patient? Right? Okay. Right? Okay. So you know when you start palpating now, there is inspection. When you start palpating, before you start palpating, you know you are dealing with the multinodular in this particular case, right? So that's why I said, you have to be a little sure that you have to tie up the age of the patient, the fact of probable toxicity, and the thyroid status, everything together. I told you, right? At the beginning of the lecture. And of course, at the time of inspection, it's very important. I mean, there is a video, so generally you should have a little bit more exposure. The supraclavicular fossa down, right? Not up to the breast. You should never expose the patient, right? Not up to the upper margin of the sternum at least, right? Okay. And you must very carefully look for scars. Right? Thyroid scars, sometimes thyroidectomy scars, right, which are done about 10 years ago, right, can sometimes be very hard to see, right, okay, neck scars sometimes be without any leaving any proper scar tissue, right, be careful about that. And so he knew that patient has a multinodular goiter on inspection itself. And one of the key things to ask is, you must ask whether the goiter is painful. Sometimes I told you there are certain painful conditions. patient says no, you can generally do. I mean, there's a little controversy about this examining from front and examining palpating from behind and front. Most of the time, the examination of a goiter is done from behind, right? So there's nothing wrong. You try to do it from front, but then that becomes a little difficult sometimes, right? And examine, it's easier to do the standard thing rather than doing something strange and trying to defend, right? Something that when you examine from behind, when you palpate from behind, there's a reason for that, right? The argument for that is this reason. In a multinodular goiter, part of the thyroid can be hidden behind the muscles, right? Okay, and when you feel one side of the gland, you must stabilize the other side of the gland, right? This can usually be done. Can you see, right? That is the palpating hand going all over the goiter, upper bone, lower bone, isthmus, and so on and so forth. Look at this hand, right? Okay, what is that hand doing is by keeping the rest of the gland steady. Otherwise, what happens is you press from here, right? Part of the gland goes there. You understand? Or goes on, right? That process is easier when you are doing it from behind, right? That's why you are supposed to examine from behind. So I think palpation just do it from behind, right? Okay, right? Right. And when you palpate the gland, right side, you always stabilize the left side, and you say concentrate on the upper pole, lower pole, middle of the gland, right side, okay, then this, right, or one, some order. Similarly, you will examine the other side. Okay, and then when you are from behind, you do everything that you have to do from behind, from there. Okay? Feel the enlarged cervical lymph, right? Enlarged cervical lymph nodes. The cervical lymph nodes, once again, there are stations, right? Subventral, submandibular, preorbital, postorbital, occipital. Coming down on level 2, 3, that is the cervical, upper cervical, lower cervical, right? Okay? Either in numbers or in units, or in descriptive areas, you should know, right? Supraspinal and so on and so forth, right? You must examine the lymph nodes in some order. Right? That is posterior cervical. A lot of people look for proptosis at this particular time also, right? Because you have night information, and then you come to the front. Right? Yeah, that is an important thing, especially in a big goiter, right? Whether the trachea is in the midline or not. Right? Do this the moment you come to the front of the patient, because this is one of the signs that aneurysm is very big. Right? Okay? The place generally to look at this is the suprasternal notch. And by keeping 2 fingers on either side, you look at the space between the left side suprasternal notch and the classical, the trachea, and the right side of the suprasternal notch and trachea. So both spaces generally should be equal, right? And you can actually feel what that's what he is doing. Right? For some reason, if the suprasternal notch is filled with the goiter, in a retrosternal goiter, you might not be able to feel the trachea or feel the space in the suprasternal notch. In that case, you can go up to the thyroid cartilage and try to feel a bit of trachea there or the thyroid cartilage itself and comment saying, you see, I cannot feel the trachea in its usual place where I feel it, but it looks either deviated or not deviated by the To see whether they are or not. Right, okay? If they are not, then on the right side with the goiter, the capillary pulses are not there. Huh? There's a bit of bleeding to be done. Please, right? Please wait. Right? Okay, these are, I told you, it's a very important. You are doing surgical appointments. Surgeons are not coming after you for these things. Doing surgical appointment. Yeah. They don't ask. Right. Okay, if the capillary parts are not there, the problem is sometimes you can have invasion by a thyroid cancer into the capillary sheath. Right? Okay. So what do you call that sign? Huh? The berry has a lot of things to do with the these things, so that is called the berry sign. But whatever, right? If that sign is there, just be very careful because that's the important sign for the surgeon. Because benign goiter can just push it's rare it pushes the carotids, but it you know how big the goiter becomes. Usually the capillary pulses doesn't become big in a benign, right? Okay, that's a sign of malignancy, invasive malignancy. One of the ways of looking for intestinal extension, right? Getting the patient to look up, right? And elevate the hands slowly, and you look for engorgement of the neck veins in front, right? And the jugular veins, branches, right? Okay? That's called the Pemberton sign, right? If you want to do it, you can turn the neck to a side and do it. So usually I do it that way, right? Then it becomes very obvious, right? Okay. Then you start percussing for external extension, right? And you always percuss from below upwards, right? Okay. Right. Below upwards, the midline of the up to the clavicle on one side and the clavicle on the other side. Right? Okay? Right? And actually this is wrong. You don't auscultate for carotid tooth. You auscultate for thyroid. Right? Okay, this statement is wrong. Right? Okay? You auscultate for bruise over the thyroid gland. Right? That's one of the features in hyperthyroidism or toxicity. Right? Because of the high restimulation of the gland, all over the glands, you can hear like bruise, right? Fluids, right? What you do is you keep the weight of the stethoscope on thyroid and ask the patient to momentarily stop breathing, right? Okay? Then only you can hear those flow murmurs. Right? It's not the carotids that you are actually looking. You can look for a carotid fluid as well. There is nothing wrong in that because you see if it's a malignant infiltration before disappearing the pulse, you can have a bruise. That's true. But generally, right? Okay. Right. So this is how you check for the lead gland. See, you get the patient to look from an object, right? Okay, and gradually bring the object down. Okay, so the patient is looking front and then upper limbs are coming down, right? Generally, the speed at which your object goes down and the lid comes down has to be equal, right? And there should be uniform, right? In in proptosis and exophthalmos or proptosis one, what happens is the lid is up there and your object will go down like this, but the upper eyelid would come slowly, right? And sometimes it holds, right? And like a shunt, right? Okay, right? Then that's called a lagging because it is coming slow than the object going down. Okay, right? Almost better here. Hold the object and at a reasonable speed you bring it down. And ask the patient to stop, follow. Right. Next. Right? Right? Ophthalmoplegia. Right? So likewise you take the sides and up and down. Right? The cornea should follow you at the same pace. I told you about the exophthalmos, right? Check the swollen palms, right? And tremors. Right? Okay, so that's it actually, right? Okay, those are the main issues of examining as good main steps, right? Nothing very unusual, right? Very straightforward. But the problem is you don't come to the exam and don't do even 50% of it, right? Then comes problems, right? Okay. Yeah. Any questions? I told you it's very difficult, telling all this in a lecture. I wish I had some patience, but it doesn't matter. You have to do the examination, right? Now, we are telling you what to do, so you go to and do the communication, right? Anything that you want to clarify? Anything you are not clear about? No questions at all? For heaven's sake, don't start measuring neck lumps, right? Okay? Thyroids, don't pull up your tape. No need, right? Because it really doesn't have much of a relevance, right? Like in a breast lump, right? A breast lump, we would like to know the actual diameter.